Hello to all my friends and my colleagues and my fans and my students everywhere. My topic today will be about pulmonary edema. By acute pulmonary edema, we mean an abnormal accumulation of fluid in the extravascular spaces of the lungs. Abnormal accumulation of water or fluid in the extravascular spaces of the lung, first in the interstitium of the lung, in the pulmonary interstitium. This is what we call interstitial edema, pulmonary interstitial edema. And then after that, when it becomes more severe, the fluid will overflow and will pour into the lung parenchyma that is intra-alveolar, and this is what we call parenchymal pulmonary edema or alveolar pulmonary edema, which is life-threatening and is associated with high mortality if not properly managed and the underlying cause not properly treated. So this is the pulmonary edema. It is life-threatening, devastating medical emergency which needs special, prompt, quick and urgent attention by the healthcare providers in the acute medical setting, because it usually presents to clinicians in the emergency care or in the emergency department. The pulmonary edema, which is, as I mentioned, the accumulation of fluid in the extravascular spaces of the lung, in the interstitium and in the alveoli, has two main or major types: cardiogenic due to heart disease, and non-cardiogenic usually due to lung or other systemic cause or systemic disease. And this is what we call non-cardiogenic pulmonary edema. First, let us talk about the cardiogenic pulmonary edema. Cardiogenic pulmonary edema, it is pulmonary edema or abnormal fluid accumulation within the lung due to congestive heart failure or due to heart failure, most notably left ventricular failure. Acute left, any cause of acute left ventricular failure or acute left-sided heart failure will result in pulmonary edema, whether this is, as most commonly happens, due to coronary vascular obstruction, that is acute coronary syndrome, and one of the commonest complications of the acute myocardial infarction, which is the ultimate acute coronary event or acute coronary syndrome, is left ventricular failure and acute pulmonary edema. It is a recognized complication of acute myocardial infarction. Also, it can complicate rapid ventricular arrhythmias, rapid VF or rapid VTAC. It can complicate rapid atrial fibrillation, uncontrolled atrial fibrillation. Also, it can complicate cardiac valvular disease, like patients with mitral stenosis, or patients with double mitral valve disease, or patients with aortic valve disease. It can be complicated by left-sided failure and acute pulmonary edema. Also, it can complicate cardiomyopathy of all its types, whether congestive cardiomyopathy or the restrictive cardiomyopathy or the hypertrophic cardiomyopathy, obstructive or non-obstructive. So acute pulmonary edema can complicate any cause of left ventricular failure, especially common in acute myocardial infarction, and this is the most common cause of acute cardiogenic pulmonary edema in clinical practice. That's pulmonary edema complicating acute MI or heart attack. And acute pulmonary edema also complicating cardiac valve disease, especially in patients with mitral stenosis, when they are overloaded with fluid or with high salt intake or with high dietary salt, or during pregnancy, or when they get any condition of hyperventilation hypervolemia, they might get complicated by acute pulmonary edema. So this is and also patients with cardiac dysrhythmias or arrhythmias, especially fast uncontrolled cardiac arrhythmias like fast AF or fast VF or VTAC. This might be also complicated by acute pulmonary edema. And then we come to the non-cardiogenic causes of pulmonary edema, and the most common causes are acute respiratory distress syndrome. It can complicate severe pneumonias, it can complicate viral infections of the lungs, it can complicate exposure of the lungs to irritants and to gases and chemicals like chlorine, like phosgene. It can also, pulmonary edema can complicate exposure to certain drugs and to salicylates. Also, it can complicate opiate poisoning, acute opiate poisoning, and morphia and heroin and ecstasy drugs can be complicated by non-cardiogenic pulmonary edema. It also can complicate other systemic diseases like patients with massive blood transfusion can be complicated by non-cardiogenic pulmonary edema. Patients with acute hemorrhagic pancreatitis can be complicated by non-cardiogenic pulmonary edema. Patients with consumption coagulopathy or disseminated intravascular coagulopathy can be complicated by non-cardiogenic pulmonary edema. Also, septicemias and septic shock syndrome can be complicated by ARDS or non-cardiogenic pulmonary edema. Also, central nervous system disease, and this is what we call neurogenic pulmonary edema, that is pulmonary edema of neurogenic origin or due to a CNS cause, like what happens sometimes following brain trauma, that is traumatic brain injury, or also in some brain tumors and in some acute vascular insults to the brain, especially to the region of the brain stem. These can be complicated by pulmonary edema of neurogenic origin, or what we call neurogenic pulmonary edema, which is one of the types of non-cardiogenic pulmonary edema. So this is also CNS causes of pulmonary edema. So as we say, these are all causes of non-cardiogenic pulmonary edema in clinical practice. The mechanisms of pulmonary edema is one of two things, regardless of the category, whether in the cardiogenic type or in the non-cardiogenic pulmonary edema. The mechanism is one of two things. Either it is increased the pulmonary hydrostatic, macrovascular hydrostatic pressure, that is the pressure within the microvasculature of the lung is high, so it allows the flow of fluid from the intravascular to the extravascular compartment of the lung and development of interstitial fluid collection and then alveolar fluid collection in the lung. So increased pulmonary hydrostatic pressure within the pulmonary microvasculature. The other mechanism is increased pulmonary microvascular permeability. Increased pulmonary microvascular permeability, in other words, increased pulmonary capillary permeability due to diffuse damage to the alveolo-capillary membrane. There is diffuse damage to the alveolo-capillary membrane or diffuse alveolar damage, which will increase or cause increased hydraulic capillary permeability to be elevated, and water will or fluid will extravasate from inside to the outside of the small vessels of the lungs into the interstitium and then into the alveoli. So it's either increased pulmonary hydrostatic pressure or increased microvascular permeability of the pulmonary microvasculature, or the two together, that is mixed pathobiology or mixed mechanisms resulting in development of the pulmonary congestion and the pulmonary edema. This depends on the nature of the underlying cause or the etiopathogenesis or the etiology of the pulmonary edema, whether in the cardiac or in the non-cardiac. In the cardiac, usually it is the increased pulmonary hydrostatic microvascular pressure, which is the main mechanism playing a role in the extravasation of fluid into the extravascular spaces of the lung and the development of edema. In non-cardiogenic and in many cases of non-cardiogenic pulmonary edema, it is the diffuse damage to the pulmonary capillary membrane and the diffuse damage to the alveolar capillary membrane, resulting in overflow of fluid into the extravascular spaces of the lung and development of pulmonary edema. And in some etiologies, there is mixture of the two mechanisms working together in the development and the perpetuation of pulmonary edema. Among the these are the predisposing causes and the mechanisms of pulmonary edema. As regards of the precipitating causes, many precipitating causes might play a role in the initiation and development of edema, like the anemia, for example, use of medications which also may enhance the occurrence of fluid overload and increase in the pulmonary hydrostatic pressure that is medication induced or drug induced, and this is usually a precipitating cause. Pregnancy also may be a precipitating cause, anemia, arrhythmias, some systemic infections might also precipitate or act as a precipitating cause of pulmonary edema. So we have predisposing causes and precipitating causes which help in the perpetuation of the pulmonary edema as a process. Most notably, as I mentioned, anemia and pregnancy and drugs and infections, and also abnormal dietary habits of the individual, especially high salt intake, and the other factors from inside, that is intrinsic or extrinsic from outside the body, which might also all share in the initiation and perpetuation of the pulmonary edema. As regards the manifestations of pulmonary edema, the patient suddenly develops, who get acute pulmonary edema, suddenly develops shortness of breathing. So acute dyspnea at rest is the most common symptom, acute dyspnea, and also cough of frothy pinkish sputum, and also an anxiety and irritability with cold clammy skin, and also with fast heart rate, and maybe with development of acute confusional state, that is disturbed content of consciousness, and also a sensation of being drowned in his own or her secretions because of the water inside the lungs. So this sense of impending death, extreme anxiety, cold clammy skin, severe dyspnea, cough of pink sputum, chest tightness, and sensation of about to die, or dropping of the heart. All of these are clinical manifestations of acute pulmonary edema, which deserve the individual to seek for immediate medical help, urgent medical help for treatment of this condition. Because if pulmonary edema is neglected, the mortality rate is very high, whether in the cardiogenic or in the non-cardiogenic causes of acute pulmonary edema. We have to do physical examination. We'll hear the crackling chest of pulmonary edema. The bilateral basal crackles first in the congestion, and then diffuse pulmonary crackles and rales in patients with frank pulmonary edema with alveolar collection of water. There is rapid heart rate, there is galloping heart, there is heart failure. If the cause is cardiac, there are signs of lung disease. If the cause is in the lung, in non-cardiogenic pulmonary edema, we have to examine the nervous system, we have to examine the all other systems in the body. After the heart, cardiac examination, pulmonary examination, as I mentioned, to exclude cardiac causes, to exclude pulmonary causes. chest X-ray is diagnostic to see the opacification in the lungs, hilar, and then the ground glass appearance of the lungs in frank pulmonary edema. Also the ECG to detect the presence of acute MI, that is acute ischemic cardiac insult. Checking blood pressure, because hypertensive heart disease and hypertensive crisis is one of the causes of hypertensive left-sided heart failure and pulmonary edema. So we have to check blood pressure. Blood pressure in pulmonary edema might be very high if it is the cause with hypertensive left ventricular failure and pulmonary edema, or may be low if it is the result of cardiogenic shock complicating and associated with the pulmonary edema, or it may be maintained within the normal. So blood pressure might be very high, very low, or normal in patients with pulmonary edema. Also, we have to do, as I mentioned, chest X-ray and ECG to pick up arrhythmias, to pick up acute cardiac ischemic event, acute MI, or unstable angina in the ECG as the cause of the pulmonary edema. We have to do simple blood tests, CBC, SR, and sometimes we have to do transthoracic echocardiography also for detection of other cardiac problems. We have to manage the patient immediately. The patient should be in the 45-degree positions with what we call head-up position in order to keep oxygenation, because in pulmonary edema there is impaired oxygenation of the tissues and the body, so we have to keep the body well oxygenated. We have to put the patient in the upright position with the head up position, and we have to administer oxygen by oxygen mask to keep oxygen saturation above 95%. This is very important. We have to start giving medications. Most common is furosemide or loop diuretics in general, especially intravenous Lasix or furosemide, 40 to 80 milligram, and then the dose might be IV intravenously or as a shot, and then after 20 minutes or 30 minutes we can repeat the dose. Also, other medications used in pulmonary edema are intravenous morphine, 4 to 8 milligram IV, intravenous inotropes, antihypertensive medications in cases of hypertensive crisis, like sodium nitroprusside, like aprezoline, like hydralazine intravenous, like intravenous esmolol. These are all parenteral antihypertensive medications in cases of hypertensive left-sided heart failure, which help to reduce the very high blood pressure. Other medications in acute pulmonary edema, depending on the clinical situation, is the use of inotropes like noradrenaline or dopamine if there is manifestations of shock with systolic blood pressure less than 100 millimeter mercury, or to use dobutamine if the systolic blood pressure is between 70 to 100 millimeter mercury with no signs of shock. So either we use dobutamine or we use dopamine or noradrenaline, depending on the presence or absence of other signs of shock, that is cardiogenic shock in association with the pulmonary edema. So inotropes also can be used. Nitroglycerin also can be used, especially in patients with systolic blood pressure, of course, more than 100 millimeter mercury, in patients with acute myocardial infarction. First, we use the nitroglycerin sublingual, and then intravenous dose 10 to 20 microgram per minute to be repeated as needed or as required, and under monitoring and under medical supervision. Sometimes also we can use other drugs other than diuretics, some morphia and inotropes and antihypertensive medications, and the nitroglycerin. We can use high dose prednisolone intravenous in patients with non-cardiogenic pulmonary edema. It is associated with increased or better prognosis and reduction in what we call the extravascular lung water. So high-dose intravenous prednisolone may be used in patients with non-cardiogenic pulmonary edema or acute respiratory distress syndrome. Also, we might have to use the CPAP and with PEEP, that positive and expiratory pressure ventilation in patients with impaired ventilation and clear respiratory failure, especially patients with non-cardiogenic pulmonary edema or acute respiratory distress syndrome. We might have to use the ventilation or put the patient on ventilatory support, namely CPAP with PEEP. And other measures will depend on the other causes and underlying cause of the pulmonary edema. So these are the different modalities of treatment which we might use. Remember at the end that we might also sometimes use an important medicine, although it has side effects and it has its limitations due to its narrow therapeutic window, and this is aminophylline. Aminophylline in patients with pulmonary edema might have salutary effects, might have good effects in some patients with pulmonary edema, whether valvular pulmonary edema or non-valvular acute pulmonary edema. Aminophylline is a drug which has its uses because of its effects on the heart to improve the cardiac contractility, and because of its also relaxing effects on the bronchi, and because of its diuretic effect, and because of its stimulatory effects on the brain. So it has many pathophysiologic benefits and advantages which make it also sometimes useful to improve the cardiac function and to decrease the left ventricular end-diastolic pressure and to decrease the pulmonary vascular pressure in patients with acute pulmonary edema, simply because of the synergistic effects of the aminophylline on the systemic circulation, on the pulmonary circulation, on the bronchi, and on the myocardium. These mixed effects of aminophylline on these physiological parameters might prove its effects in reducing the pulmonary capillary pressure and reduction of the pulmonary edema in patients with acute pulmonary edema. Thank you so much, and I hope that all of you had benefits from watching my live video about acute pulmonary edema in clinical practice. Thank you so much.